Hey, it's Dr. Jaime, and let's talk about the importance of salt and electrolytes. If you're living the low carb life like me, your requirements are actually much higher. And there's only one source that we trust in our home, and it's the people and products at Redmond Real Salt. They keep us coming back for more every time. Real salt's an all natural, unrefined sea salt harvested from an ancient ocean. It's full of natural minerals that make it healthy, delicious, and pink or red looking. They're also the best selling brand in America's health and food stores. Redmond Real Salt is so pure, it's free of pollutants and microplastics found in many other natural refined salts. The Redmond Salt Deposit is in Redmond, Utah, where the team enjoys award winning work conditions and generous pay. And since they own and control the whole process, you can be sure that real salt comes to you through their world class production facilities in its unrefined, mineral rich, delicious state, exactly as nature intended. Redmond has amazing natural products, including salt, electrolytes, toothpaste, and so much more. So check out the entire line at www.redmond.life, where you can use my code DRFIT, that's DRFIT, for a discount on all Redmond Real Salt and Relight products. Welcome to the Fit and Fabulous podcast with Dr. Jaime Seaman. Hello, everybody, and welcome back to the Fit and Fabulous podcast. It is so great to have you here with us today. Just want to say how much we love and appreciate all of our listeners for every episode that you've listened to, you've downloaded, you've left reviews, you've sent it to your grandma, you've sent it to your coworkers, because what we talk about on this podcast literally changes people's lives. And so we need you to keep spreading the messages for us. I have two great guests today on the Fit and Fabulous podcast. One of them, I'm sure, is well known to you. Dr. Tro, welcome, and Dr. Laura Buchanan, both of you, welcome to the Fit and Fabulous podcast.
Thank you so much. It's great to be here.
Yeah, it's awesome. It's nice to connect again.
Okay, so I want to start off. Please tell our listeners, Dr. Buchanan, let's start with you. Tell our listeners just a little bit about your background and who you are and what you do so they can get to know you.
Yeah, for sure. So grew up, loved playing sports, played soccer, tennis, played soccer in undergrad. And then also got to work with a tennis player on the junior pro circuit, traveled in South America. It was an incredible experience. And then I eventually went to med school and went through family medicine and graduated from residency this past July.
Incredible. Congratulations. I know that road is not an easy one, but you're on the better side now. You get to really start making an impact in people's lives. Dr. Trope, for anybody that doesn't know you, maybe living under a rock, can you introduce yourself to our listeners?
Yeah, so I'm Dr. Tro Kalasian. I have a clinic that's in New York, but we're basically a telemedicine practice. We're in 50 states. I lost 150 pounds 7 years ago. When my wife was like, Tro, are you going to die before our kids make it to 10 years old? I have three little ones, like you have three little ones. And it's funny, my wife is like your hugest fan. So I just got to say, she's like, I don't want to say, she just loves your content. You inspire her. Anyway, we got three little ones, like you have three little ones. And we saw you were on a cruise recently. She's like, did you see they were on a cruise? We were on a cruise 3 years ago. She's like, we should go again. Anyway, she was like, I was a board certified doctor. I should have known better, and nobody really taught me metabolic health. They taught me calories in and out, and they taught me thermodynamics. And when I was 350 pounds and chief resident in a Yale internal medicine program, they said, well, maybe you're just eating too much. And really, nobody really had help for me. And I had to, just like you, I had to figure out a way to make myself hard to kill. And, I had to go to the medical literature, read all the books myself, 300 diet books. Some of them are back there, including your book. And then, 3 textbooks on obesity, 3,000 papers, right? And then, then you see that what we were told and what we get from the mainstream isn't really true. And, most likely a low carb diet is probably how most people with obesity should start in our modern world. So I had no skin in the game. I was just a fat guy, fat doctor, couldn't sleep, had pre-diabetes. I know you relate to that, and tired all the time, messed up hormones. And, I was like, how do I break free? And that's how my journey started. Then fast forward, you go down all the rabbit holes that I know you've gone down, and you end up losing 150 pounds, and you're like, I can't stay in an academic institution telling people eat less and move more. I can't, I went on to get obesity medicine certified. I'm like, maybe these people, maybe the obesity medicine doctors, they'll be better. They'll understand. And then you go there and I got certified through them, and it's like shakes and, surgery. And I'm like, what is going on here? So that's my story. I lost 150 pounds and I changed the way I practice medicine. And now, I'm trying to spread metabolic health. Everything I'm doing is about metabolic health. And I've been hoping somebody like Dr. Laura would take a chance with a practice like ours. And here she is, inspired to help people age gracefully. And she's like, Tro, let's do this. So I'm game, I'm fueled, I'm pumped. Now we've got 5 studies under our belt. I want to make it 10 now.
I love it. I love it. We have so much to unpack with what you just said. And something really resonated with me that you just said. The co-medical director at Upgrade Performance Institute, which is our gym here in our town that we opened, Dr. Brad Winterstein is a bariatric surgeon, and he works for a hospital system and, does gastric bypass, does weight loss surgeries for patients. And his institution will not allow him to say the word ketogenic diet to patients. I mean, it's literally not an option that's put on the table. They work with a dietitian, but that's not, and what I consider to be metabolic therapy, it's not on the playing cards, which is really sad, because I think if you look around at a lot of doctors around the world, they're not the example of health and fitness. And for somebody like me, like you, Dr. Laura, I have an athletic background, right? So I went through all this nutrition, exercise science training, and then I get to medical school, and there was no merging of the two worlds. And now I think that's the solution. I have this vision of gyms and clinics in the same building. And so I'm interested for you, Dr. Buchanan, to just share a little bit, because you are fresh out of residency. Clearly, the way that I practice and the way that Dr. Tro has practiced now for many years is not the traditional mindset of Western medicine. So please tell me, where in your journey did you feel going the route of adopting, metabolic therapy, lifestyle medicine was the right path for you?
Yeah, absolutely. So it stemmed kind of from something you said about the nutrition education in med school was just not adequate. I had my 2-week nutrition course where I learned if you had vitamin C deficiency, you were going to get scurvy, but you did not learn how to treat or prevent chronic disease with nutrition. And so after finishing that course, I was just left very frustrated. And so I started diving in and doing my own research, and I stumbled across the Low Carb MD podcast, Peter Attia's The Drive, Jason Fung's Obesity Code, Nina Teichel's, Gary Taub's. I just kept digging, and I was like, this stuff is awesome. These people are changing lives without medications. They're actually taking people off medications. They're making a real difference. And that stuff got me excited. So from there, in 4th year of medical school, I wore a continuous glucose monitor for the first time. And I was eating every day these, quote, healthy oatmeal fiber cookies. I'm trying to get my 50 grams of fiber. I was like, I got to get it. My sugar was going above 180 every day. And so that was just a huge wake up call, in addition to everything else I was learning. And I pretty much went low carb at that point. And then just as I kept digging, became a certified metabolic health practitioner through the SMHP. And then fortunately, got in touch with Tro, and excited to start working with him. One step back to your question, it really, in the start of residency, I started using low carb because I had seen the CGM, I had seen the research in med school. So day one, I was like teaching using low carb, and the results were incredible. You can't unsee it.
Yeah. When you were in residency, like when you're seeing patients in the wards and in the clinics and things like that, did you try to bring these things up with some of your, staff, your advisors? Like, how was that received in your training?
Yeah. So different, sometimes okay, other times really not well, unfortunately. I can remember I was on the pediatric wards. We had a 12-year-old admitted with new onset type 2 diabetes, and his A1C was 12. And for the following day, he had pancakes with syrup for breakfast. We had to give him a lot of extra insulin because his breakfast was pancakes with syrup. And so I suggested to our attending if we could use a low carb diet. And the attending said, "Are you trying to give him a heart attack?" I was like, "No, but I'd like to not give him 20 extra units of insulin, at the age of 12. And we went back and forth a little bit, and I asked for data. And in the end, we let him eat whatever he wanted and gave him enough insulin to cover his carbohydrate intake.
Yeah. Yeah. I remember when I was on GYN oncology as a resident, it was part of the staff standard protocol to put the patients on D5. So the patient's getting dextrose, through their IV. And I would constantly get called in the middle of the night that they're hyperglycemic. And the staff's response was to put them on an insulin drip. And I was like, these are cancer patients. Like, this doesn't make sense to me. Why don't we just turn off the infusion of the sugar? And that was like my first kind of like, this just doesn't make sense. And that's when I was in training, when I started to kind of think about it, but it wasn't until I was out in practice that I was like, we are just like, are not doing this right. Like, this is not helping people. So Dr. Tro, over to you for a second. You put out an Instagram post recently talking about lies that your doctor has told people. So I want to unpack these. Let's talk about saturated fat and heart disease. I just had a New York strip steak for dinner, and my kids had a little bit of fruit with it because I think that's fine. They're like kids and they run around like crazy and they're really active. They all had softball and basketball practices and things like that tonight. But why is saturated fat get such a bad rap? And why is it not as big as a problem that you're saying?
Yeah, so it goes back. I mean, this is like a deep rabbit hole, and probably people like Nina Teicholz could do a lot better than I could. But it starts with the mantra back in the 70s and maybe even a little bit earlier that saturated fat raises LDL. LDL is the causative risk factor for heart disease. Except here's the problem with that whole line of thinking. We know that when you're looking at cardiac risk factors, diabetes gets 2 points. So if you remove saturated fat and you put in its place polyunsaturated fat and processed sugar, I should say, rancid polyunsaturated fats and trans fats and a bunch of sugar and processed carbs, right? What are you left with? You're left with essentially the insulin resistance and diabetes, right, in the making. So the idea was, let's stop disease and let's get rid of saturated fat. That never really panned out, right? And it was all based on kind of epidemiologic data, faulty data. And, there's been data since then of similar types, even broader, like the PURE study that showed that actually it's carbohydrates that are associated with heart disease and not saturated fat. So saturated fat gets a bad rap, and I had the same for dinner. So nice New York strip, sometimes ribeye, tons of eggs, and no, my LDL is completely predicated to my meal frequency and my carbohydrate intake, 100%. And this is the study we published about a year ago. We showed that people who are low carb, it has very little, the amount that their LDL goes up, right, has more to do with their weight and their meal frequency and their baseline triglycerides and HDLs than it has to do with how much saturated fat they're taking in. So much so that we literally had people in our clinic with 700 LDLs that we were able to walk down to under 190, which is the cutoff for familial hypercholesterolemia. So we reversed familial hypercholesterolemia in our clinic, and we published these findings. We didn't exactly do that. I mean, I'm saying familial hypercholesterolemia with quotes for people in Apple Podcasts and Spotify, because if you have an LDL above 190, you're automatically assumed to be that, right? And it was assumed that saturated fat made it worse.
Mhm.
And all we told these patients is, hey, wait a second, your baseline LDL was normal. Maybe if we just add a tiny amount of carbs back, right, to feed the liver, those LDL receptors will change and we can reverse these findings. Anyway, that's a long story to tell you. We've actually looked into the data. Red meat has been exonerated. Saturated fat has been exonerated. And in people who are low carb, who see their LDL skyrocket, it has more to do with their carbohydrate intake than it has to do with their saturated fat intake. So yeah, saturated fat is not, and in fact, low carb diets, calorie for calorie, okay, they lower the plasma saturated fat, right? Because you oxidize fats more readily. So you will lower your plasma saturated fat. So yes, I think it's BS, and stay away from my Instagram feed because it's much more naughty than yours is. So I say a lot more controversial things.
Yeah, I'm not one of the lean mass hyperresponder types. My LDL is actually less than 100, which pisses off the cardiologist. But I was talking to oh my gosh, who's doing all the lean mass? Yeah, I was talking to Dave at Metabolic Health Summit this year, and he thinks, and he has some very interesting data coming out, by the way. I can't tell you what they're finding, but he thinks it's because of the level of resistance training that I do that my LDL is lower. I don't know. It'll be interesting to see what he puts out, but I agree with you. And the American Cardiology Association came out a couple years now. I feel like it was maybe 2019, 2020, but showing that saturated fat is not the cause of heart disease. Okay, one of my followers, you're talking about Instagram, one of my people came on one of my posts and said, the brain needs carbohydrates.
You're making me cringe. Is that for me or for you?
You treat a lot of people with low carb. What happens to their brains?
Yeah, they get better, right? They get better. I mean, besides the fact that low carb and ketogenic diets have been shown to mildly, I would say this with some hesitation, improve cognitive outcomes in traumatic brain injury, certainly improve seizures, certainly improve migraines, right? Like hands down, there are studies showing that, drug-resistant migraines, drug-resistant seizures improve with a ketogenic diet, meaning a low-carb diet. Yeah, well, it's true. So this is most of dietetics. It's a bunch of half-truths, right? It's a bunch of half-truths. The brain needs sugar, but your body can make its own sugar, so it's kind of a moot point. I mean, Laura, you hear this Dr. Laura, you hear it all the time, right?
Yeah, well, this makes me think of it was such a frustrating circumstance. So during residency, had this 60-year-old guy was saying, prescribed him a CGM to help with his dietary modifications. He did not have diabetes, but he did have obesity. He lost 30 pounds. He said his energy levels were amazing. He had gone keto. And he started working in his yard instead of hiring someone to work in his yard for him because he felt so much better finally. I graduated residency, touched base with him a month later to see how things were going. And he said when he went back to his old PCP, he said, hey, I'm glad you lost that weight, but I'm not refilling your CGM because you don't have diabetes. And also, did you know the body needs more carbs than keto does? So you need to start adding carbs back.
That's crazy. I can't tell you how many people I've been told, how many endocrinologists have called me, you inappropriately reversed fatty liver, you inappropriately reversed diabetes. I mean, it's getting to a joke. I mean, you see it with your good friend, your OBGYN, your mentor. He can't even say the word keto. I tell my patients, if you're talking to your doctor, don't use the K word. Just tell them you're modified Mediterranean, which is essentially true. It's modified Mediterranean. But yeah, the brain doesn't need sugar, doesn't need dietary sugar, unless you have a rare, glycogen storage disease, maybe. Even then, maybe. Even in glycogen storage disease, a low carb diet is used. Even in like McArdle, like all these glycogen storage deficiencies in adulthood, they're all using low carb diets, right? So it's a bunch of crap. Sorry, can I say crap?
Yeah.
Am I allowed to curse? Is that like, I know it's Oklahoma.
Children away. Dr. Tro's about to tell the truth.
Okay. I don't know. In the Midwest, if cursing is like still endearing, you know, out here in New
Yeah.
York, it's endearing.
Well, I think this brings up a good question that I'd like a response really from both of you. So I think there's a lot of misconception out there that when we say low carb and ketogenic diets, they're the same thing. It's ketosis, it's carbs less than 30 grams. How do you, when working with patients, if you reverse their insulin resistance, do you ever allow them to add carbs back in? Now, obviously, we're not giving permission for people to eat chocolate bars and potato chips again, but do you think that there are people that can restore insulin sensitivity and eat maybe more like a paleo diet or a different modified Mediterranean diet? Like, for instance, for somebody like me, I carry a lot of muscle, I'm leaner. I can usually live in like the 50 to 70, maybe at most. But even then, when you're just eating whole foods, I mean, I'm not eating rice and quinoa, but you know, maybe some more sweet potato or something like that. How do you determine if they should be low carb, low glycemic index, therapeutic ketosis? I'd love to hear both of you respond to that.
Yeah, Dr. Laura, I'll let you take it first and then I'll cap it off.
Yeah, so typically I just talk to the patient and it's a very individual, what are their long-term goals? Oftentimes we try to start keto and then so start with less than 30 grams of carb per day. And if they're feeling amazing at 6 months and they're like, I don't want to add carbs back, great, no need to add carbs back. We'll monitor their labs, make sure there's nothing else going on. If at some point on their journey, they say, you know, I think I want to add more carbs back and I want to see what happens. I say, great, let's do it. Maybe add 5 grams of carb at a time and see how your body responds, see how you feel. And then each week you could add an additional 5 grams or so and just see at what point, you know what, I don't feel as good as I used to. I'm going to go back lower carb. And that's been a pretty effective method for people to see what feels good to them.
So I think from my standpoint, it matters what's the issue. Is it nutrition or is it behavior? So if there's a behavioral issue or meaning when I say that a behavioral issue, I mean like a issue related to food. And I speaking firsthand, you know, when my wife says maybe you shouldn't eat that, you know, the first thing I say is like, leave me alone, I know what I'm doing, right? Like my emotion, like why, if my wife said, you know, hey, you got a flat tire, I wouldn't say like, leave me alone, I know what I'm doing. So there's an emotional aspect to food. And so if there's an emotional, psychologic aspect to food that needs to be explored, developed, worked through, right? Then honestly, I'd rather get those people, you know, as strict as possible, right? And as low as possible. Let's focus on behavior, right? As we keep you as low carb as possible. And that may be very dirty keto at first, and that may evolve over time. If the ideal is real food, you know, real food always includes carbohydrates. You know, you were talking about your kids. My kids eat nuts. You know, my kids have fruit. I don't withhold these things. They have carbohydrates. These are natural carbohydrates. Sometimes they do have potatoes, right? And so do I think that they need to be restricted? Do I think a bodybuilder needs to be restricted? Do I think somebody with a ton of lean mass, you know, do they have to be restricted? I don't think so, not as much, right? But if you look at, you know, metabolic syndrome is preferentially reversed with low carbohydrate approaches. Diabetes, the glycemia in diabetes is preferentially treated with lowering your carbohydrates. So as the population becomes more and more diabetic and more metabolically ill, low carbohydrates becomes easier and easier to prescribe, and the lower the better. So if we're talking about disease, right, then it's, you know, the nutrition is very clear. Hypertriglyceridemia, metabolic syndrome, you know, blood sugar's out of whack, lower your carbs as low as possible, right? Now, the question you're raising is, well, what if you're like, you know, somewhat reversed now? Like you and I, we have a lot of more mass than we did before. We've lost our fat mass, right? We probably have more reserve for carbohydrate than we initially did. I'm sure if we did clamps, like, you know, hyperinsulinemic clamps on our pancreas, we'd see that we could tolerate, if we did 3 or, you know, you do oral glucose tolerance tests probably all the time in your patients.
Yep.
So if we did those on us, we'd probably see improvement, right? So now the question is can we tolerate it? Yes, we can. Well, does that mean those carbohydrates are going to make us any more, less hungry? Probably not. They'll probably make us more, the fact that we still have those post-glycemic drops, we're still going to be hungry. The fact that potato chips and chocolate taste great, you're still going to be hungry. So I think, yes, theoretically, you can tolerate more carbohydrates. And certainly if you have no food relationship issues, go for it, experiment with it, see what it does to you. I think the people that really have to be careful, the people like me and most people, the yo-yo dieters, the people who struggle their whole life, those people, if your emotions are not like, if you don't, if you think that if you feel addicted to food, right, that's probably best to just stay as good as you possibly can. I don't know if that makes sense, but I mean, like, what do we do? I'm the low carb MD guy. I did the study with Dave Feldman where we gave carbs back to people. I'm not being dogmatic. We literally had the leanest people you can get. And we're like, maybe you're actually carbohydrate deficient if that is a real thing. And we gave them carbs. We literally did what you said. Here's some sweet potato. Here's a little bit of berries, just 50 to 100 grams. They went from like 0 to 1,500 grams, and somebody's LDL went from 797. Okay, I don't think I don't think anybody's seen a higher LDL before, and he went down to under 190. Right, just with carbohydrate.
Going from how many carbs to how many carbs?
He went from 0 to 20 to probably 50 to 100.
Yeah. So, which is still considered a low carb diet by.
He's still ketogenic.
Yeah,
because he works out like a beast and he's lean like you are and I am, right? So he was still ketogenic.
Yeah, I can eat 30, 50 carbs and I still produce ketones.
Yeah.
Maybe even more than that if I work out real high intensity. I think that.
What do you think? Like, am I being too, so I base it on, whether it's how lean, are they healed? Are they lean? Are they, is there, psychological issues? Is there, because it's two separate beasts. All those people that we, reintroduced carbs, they had a great relationship with food. They're okay. They're, no signs of compulsion, no signs of weight regain, no signs of, they were good to go.
Yeah, what I hear patients say is, and I've experienced this myself, as they titrate carbs back into the diet, they start to have more cravings, they start to lose their satiety, and it starts to be a slippery slope, especially if they came from a place of binge eating or a problem with their relationship with food. Right? Like emotional problems they haven't dealt with, or stress in their job, or stress in their relationships, or whatever it is. It seems to be adding carbs back in seems to be detrimental for those types of patients in my clinical experience.
Yeah, 100%.
To add to that, I know this is going to be controversial to say, but I've used it with some of my patients and it really resonates and they get it. And someone who has alcohol use disorder, which is, we use that now instead of saying alcoholism. Someone has alcohol use disorder, they probably should never add alcohol back. Abstaining is the best treatment option. And some people might have carbohydrate use disorder. And for them, adding carbs back would be a terrible slippery slope that just would ruin all of the success they've had.
Mm-hmm. With that being said, I don't know if you guys know, but on October 1st, I went sober and I'm doing it for 365 days to just experience it. It's called Hard to Kill 365. I've been sober. Obviously, I've had 3 pregnancies in my lifetime, and I didn't drink when I was prepping for my bodybuilding competition. I don't think I have an alcohol addiction, but my father is a recovering alcoholic. But it has been incredible announcing this on social media and hearing people's reactions. And I think there's so many parallels between like carb addiction and food addiction, right? Like nobody judges you for like eating a donut, but I'm like, I'm not going to drink. And they're like, what? Like, yeah, I'm like a healthcare provider. Like it literally adds nothing to my health. Like, but these just like super judgmental, like,
wait until the people come out with the, actually 2 to 12 drinks is healthy, the healthy user bias. I'm sure did anybody throw that data out at you? Or
well, somebody said you clearly have proven that you can drink in moderation, right? I mean, my biomarkers are great. like I don't have signs of disease, and like I get what they're coming from. But for me, it's like I'm just on a path of like I want to perform the best I can. And if having a couple drinks a week makes me 1% less of the human that I want to be, then why do it? And I think it's almost like the same thing with low carb and ketogenic diets, why people feel like they have to explain themselves to their doctors or explain themselves to their friends and family, like what they're doing. It's just like, I'm just trying to be healthy and I'm just trying to be a better human. And I'm trying to find the pathway that will make that happen.
Yeah, I think our society has moved away from excellence, and if you look at medical schools now, it's pass fail, right? If you look at USMLE, I think have they gone to pass fail? Maybe Laura, you know better than I do. Has USMLE gone to pass fail? So, which may have some benefits, right? It may have some benefits, meaning like people just don't test well and perform well. It may be like a benefit to them. But I think if you look at our society in general, like I feel like we've moved away from like people who pursue excellence, they're like, people want to bring them down, and what you're doing is like, hey, this is my path to my excellence. And people are like, well, just have one, and the minute somebody goes on a diet, like I have diabetes, I'm going on a diet, like I will have a cupcake. Like that's bullshit. Like, what is wrong with our society that we just are okay with bringing people down and we normalize it, and not to say like you shouldn't enjoy it. Like if you want to have a cake, have a cake. We're all grown ups, you make a choice, but the amount of social pressure to be a certain way that's suboptimal is insane. I don't know if I'm being too controversial here, but all this messaging on eating bugs, like what, like have you had the cricket flour yet? Or are you doing the cricket flour? Is that optimal? Does that make you hard to kill? But like there's this social pressure, or like, hey, the environment's an issue, so you should eat suboptimal food, right? I think that there's something has happened and it's kind of frightening. Like I want to make every single one of my patients' lives better in every possible way. So much so that you can text our office, call our office anytime, right? If we don't get back to you, then we'll get back to you the next morning. But like, we want to help. Our entire mission is reverse diabetes, reverse obesity, because we want to make you excellent. We don't want to be those people who took your money, right, and left you with a bunch of shame and guilt and left you with nothing, right? But self-blame. Right? Who didn't address your emotional issues, your psychological issues, your hormonal issues, right? Who didn't do that, right? Like, why are doctors not like inspiring excellence in their patients? It just makes me go crazy. In our 6-month program that we did with this employee health, we did an employee health program, right? A company came to us, said, we want you to spread metabolic health. We listen to Jaime Seaman, we listen to Vinnie Tortorich, and we want you to make a metabolic health program in our company. And I said, well, I don't know, I know people coming to me, I could be successful, but I don't know if you give me random people that I'm going to be successful. So I was like, let's start with 15 people or 10 people. I forget what it was, but something like that. And let's see how we do, right? The average person that we took in the first 6 months lost 40 pounds. Their A1C came down 1.1 while we reduced, over $4,500 of medication, including insulin, including GLP-1 drugs, including metformin, including, all these medications, right? We stopped that and we still lowered their insulin, 1.1, more, while stopping drugs. We lowered their blood pressure almost 20 points while stopping medications. We dropped their cardiac risk 44%. And this is using the AHA ACC calculator, right? 44%. And how do we do that, right? By being available, by showing them the path to excellence. And it's not like, hey, I'm going to shame you into it. It's like, no, let me be a resource for you. Mm-hmm. Hey, when you get a flat tire with your car, what do? You pick up the phone and call right away. Now you got AAA for your metabolic health. And with the CGMs, with our app, like these people's lives are transformed. So much so that we reverse diabetes in the families of our patients, right? So in 6 months, this company was like, holy crap, you just saved us more than we costed, and everybody's raving about you. So now we're at like 75, we're going to be at 100, probably 125 people by the end of this year. We can't even catch up with the amount of disease reversal. This second group now that we have is already lost 500 pounds. We added on another 20 patients. 3 months, down 500 pounds. I mean, while stopping meds, right? So it's, I think, and you want to know this, let me, like, this is excellence here. This is like the pursuit of excellence. This is what you were talking about. The average patient in our program has somewhere between 300 and 500 touch points with our office. Getting on a scale, using a CGM, using our app, texting us, talking to a health coach, going to a meeting, meeting with their doctor, messaging our front desk, right? They are interacting in some way with our office between 300 to 500 times in 6 months. That's excellence. And you know what? And it's not like, hey, you know, why don't you just have a little bit? It's like, no, you have fatty liver. You probably should quit alcohol. The CDC says under 12, but they don't give a crap about you, right? They don't give a crap about you. The CDC says for women under 6, right? They don't care if you perform 2% better. Sorry to go on a monologue here.
No, I think you bring up an interesting point too, right? How often in training, like this would be a great question for you, Dr. Buchanan, like how often are you taught to deprescribe? Like deprescription is not something that most doctors do. It's just easier to send in 6 refills. And I think that that's just another example of just mediocrity. Like you're in the hamster wheel. It's just easier, just refill it. I don't have time to teach this patient how to eat right. And I don't even have the tools myself. And I'm always looking at med lists. What can I deprescribe? How long have you been on this sertraline? Oh, 16 years. Has anybody ever tried to wean you off of it? Like, let's talk about why you're on it. Oh, because you're obese and you're depressed and you don't like your life. And it's just, so I'm interested, Dr. Buchanan, like in your training, because you're most recently out of all of us, like, did you ever see deprescription?
Probably did not see it much outside of my personal clinic.
Yeah. You were thinking about it.
Yeah. The times where there was education on it is primarily in the studying of geriatrics. I think definitely with geriatric
pharmacy.
Yep, exactly. And so we had, several lectures on that topic, and we also had some great geriatric doctors who did help and, how to go about doing that process. But in a younger patient population or in patients with diabetes, you never deprescribe. It's always adding things on.
Yeah. And like when you look at the data, I mean, on average, people are on like a handful of meds by the time they hit age 50, age 60. Like, I don't even know what the current number is, but it's significant.
I think it's like average 5 medications now per adult, adult US population, which is incredible. It's incredible. But you know what? Dr. Laura came out. So she rotated for, you know what really piqued me onto her? Can I just tell Dr. Laura, can I share this with? She came to me, I was only after Eric Westman and Mark Cucuzzella, right? So like there was nobody, I was like, all right, fine. Those people are definitely much better than I am, right? So she's like, I want to come to you next. So that was like so in the 2 weeks you were here, I'm just curious, if you had to put an estimate on it, how many meds did you see deprescribed?
I mean, every single day there was meds deprescribed, probably multiple times a day, maybe. So over the course of 2 weeks, you would think 10, at least 10, 5, 10, 15. I mean,
you're right. We never trained on that either.
No, they never talk about how you get them off the medication.
And you mentioned SSRIs, there's some data, what's interesting is, and this is published in the New England Journal, 60% of people can come off of an SSRI for mild to moderate depression with no relapse of symptoms in 12 months, right? 40% may require going back on it. But shit, that's 60% of people don't need it. I mean, I don't want to say don't need it, but may not be experiencing significant benefit. They may be able to get counseling. They may be able to change their life, address some of the issues in their life to be able to to improve their symptoms, I mean, 60% is still a big number.
Yeah, I mean, and we have data that low carb ketogenic diets can be extremely helpful for anxiety and depression. And there's some animal studies even looking at offspring. You know, what we're going to find out, that's what the pregnancy space that I play in. I mean, the epigenetic modifications, like that's why I'm so passionate about prenatal and, you know, and intrapartum and postnatal diets. I just think like, I mean, you're talking about impacting people for generations to come. Let's pivot a little bit. Another thing you talk very openly about on social media is breakfast not being the most important meal. Intermittent fasting kind of became a hot thing in the last year or two. And talk about why eating multiple times per day isn't better for your metabolism. Talk about your views
How in depth, who is it, me or Dr. Laura?
and
What do you
talk
want to
to
go?
like the regular person can understand what we're about to say. Should people intermittent fast? Should they not?
Well, okay, so the controversy right now is, do people get enough protein and does it lower lean mass? Right? I mean, you know the field to know that this is like the big thing now. Like maybe it's gonna cause a decrease in muscle mass. So I think it's about the end point, right? If fat mass accumulation is your issue, right? Probably go ahead, intermittent fast. You're not hungry, don't eat. If you're, you know, bulking, if you're looking to get stronger, more times where you initiate muscle protein synthesis through the ingestion of, you know, proteins is probably slightly more beneficial. So my advice is, depending on who you are and what your exercise routine is, probably you can eat less than 10 times a week and you're going to be fine. You're not going to, you know, if you're heavily invested into resistance training, you may need some more protein hits throughout the week than the average person. The other part of this is there was a study by Ethan Weiss, which was pretty terrible, that showed, and I'm just going to be very honest about it, it showed left arm appendigeal lean mass decreased, and that powered his entire study that, you know, intermittent fasting lowers lean mass. And if you look at that study, the problem with that study was that the group that was intermittent fasting was eating at 8 o'clock. Right? They were 12 to 8. And we know that eating very late disrupts sleep, right? They were also less active. They had poor sleep quality, less deep sleep. So I think the real problem with intermittent fasting is a late big meal, right? So that's a problem. The question is it bad for lean mass? I don't think particularly so, unless you are working out as much as you and I or more, right? Yeah. That's my take. So yes,
I think if you're in ketosis, it's very protective to the lean mass. And we know that if a patient has to lose 100 pounds, ketosis is very protective to the lean body mass, in my opinion. And that's been shown in studies. But I think that you're exactly right. And you said, like, if they're not trying to get stronger, I would argue, like, why are they not trying? I mean, I think we really have to encourage people to, instead of, you know, working on losing fat, if you work on gaining muscle, like, you will lose that. And I know everybody has to start somewhere. And I think diet, when it comes to weight loss, is far more important than any amount of exercise. But I think that as a medical community, if we focused on building lean body mass and getting patients as strong as possible, I think it would really help battle a lot of the.
I know somebody who's all about that, who's even got a gym, you know?
Yeah.
Yeah. Yeah, you're my role model. I got to be honest with you. When I heard what you guys are doing, I was like so jealous. I was like, that's the next thing I got to do. Give me a couple more years on my belt. Maybe Laura, we'll get that happening soon, right? We'll get a nice gym.
I was about to say that is long-term goal. Definitely having a gym on site.
Well, when I was out at Metabolic Health Summit, you know, Colin Champ, he's a oncologist, and he presented this really cool data on breast cancer patients and some other cancer patients. And they have a gym in their clinic, and they put them into these resistance programs, and they have them doing box jumps and all this stuff. And they have better outcomes. It mitigates side effects of their treatment. It saves their bones and their lean mass as they're going through treatment. Like it was really cool data. And I'm like, okay, that's awesome. I was like loving it. Okay.
You intermittent fast? I'm just curious. Do you do it? And Laura, I know you do it, right? Maybe do you do
Yeah.
it?
Here's how I talk. Well, first of all, how I talk to patients about it. It's a tool. It's a tool that will help you if you're looking to calorically restrict, because I think it gives people a more rigid parameter. Like when they can only eat in a certain window, it doesn't allow them to graze and snack and do some of the behaviors that led them to where they're at. So I think
Easier to count hours than it is to count calories or
now,
portions.
yeah. Now some people will argue that that's all it is it's just a tool for caloric restriction, and all the benefits of intermittent fasting are just because you're calorically restricting. I would argue that that's not true. There are studies that show even when calories are equated, alternate day fasting, which it really actually was, it was eat breakfast, lunch, and dinner one day, dinner the next day, breakfast, lunch, and dinner one day, dinner the next day. It still reduced their fasting insulin by 50% by just doing it that way. So I would argue it's not all just because of caloric restriction. Even when calories are equated, there are benefits to not eating for certain hours of the day. And now for me, when I first started doing keto, I was intermittent fasting. And for me, it was great because I'm a surgeon and I'm busy and I don't have time to eat 6 meals a day. So I loved that. But now I'm at a point where for body recomposition purposes, I'm training to gain as much muscle as I can. And I feel it's more advantageous for me to get multiple protein boluses throughout the day. It still doesn't happen. I live, a crazy schedule, but as I got leaner, I actually didn't tolerate fasting as much. When I was bigger, I tolerated it just fine because I had plenty of body fat. But the leaner I got, I did not tolerate it as well. So,
so you're like 2 to 3 protein boluses a day right now?
Yeah, I eat kind of a post because I work. The problem is that I normally would fast till noon, but I work out at 5 in the morning, and I would come home from the gym and be like hungry, and then I'm like, do I really have to like wait till noon to break this fast? And on days that I don't train, it works out fine. But on days I train, I do protein after I work out.
So you basically do protein, lunch, dinner, and then if you don't work out, you're doing lunch, dinner.
Yeah, exactly.
Yeah, so you're like a 2 to 3 meal. That seems pretty reasonable.
Yeah. So that's just what works for me.
Laura, I'm just curious, Laura, do you do
Yeah, so I've rotated or changed recently actually, where I've now added in kind of an extra protein basically. So I was waiting till later in the morning or closer to lunchtime for a meal, but now I pretty much every day will get just almost like Greek yogurt or some type of straight protein, basically with not a ton of fat, not a ton of carb, and me kind of start the day off. Usually after, if I play tennis for 2 hours, because I really picked up my tennis and resistance training, it'll be after that.
Tennis for 2 hours. I just want to know what that's like. I think we need to gift her 3 children, Tro.
Yeah.
Maybe like just for the weekend, Dr. Laura can, take them and teach them how to play tennis. I love it. I love it. Okay. You recently had a post about ketogenic diets and testosterone. I don't know about where you guys live, but I work in the hormone space, and so many men and women are going to these hormone clinics. It's your hormones. You need hormones. They're getting put on testosterone replacement therapy, PRT. I'm a huge fan of menopausal hormone replacement therapy, but you made a post recently, Dr. Tro, about keto and testosterone. Can you talk about that? Because we are in a low T epidemic.
Yeah, I mean, so bottom line is there's a couple of things. So most aggressive caloric restriction protocols will lower testosterone in men, right? This has been shown. Bodybuilders who are very low carb, very low fat, usually high protein, this has been shown to lower testosterone when they get very lean and they're in a caloric deficit. And there's been several studies that have shown that a ketogenic diet higher in fat, higher in cholesterol, which supports hormonal production, actually doesn't lower testosterone. In fact, increases testosterone, particularly in the obese. So I think there's something to be said about supporting our hormonal health. Meat eaters in general have higher testosterone versus vegetarians and vegans. So that exists in the kind of epidemiologic data as well. Bottom line, if you have low T and you have metabolic syndrome and you don't address insulin resistance and you don't cut carbohydrates and processed food, you're basically like, putting out a fire that's got somebody pouring gasoline on it. I mean, like that's what you're trying to do. I mean, it's never going to work. So I don't like replacing testosterone until I know that metabolic syndrome and insulin resistance have been reversed, because 9 times out of 10, the testosterone will climb up, right? So particularly in men. Now in women, we've seen the testosterone come down in PCOS, so which is like mind-boggling to me, right? It increases testosterone in men. The same diet decreases testosterone in women with PCOS. So, maybe there's some sort of hormonal balancing that, eliminating sugar and processed carbs and going back to real fats does.
Well,
Now,
it restores their FSH to LH ratio. So that's the mechanism in PCOS that helps, because testosterone is all made from the theca cells in the ovary, and that's actually, then it goes to the granulosa cell and makes estrogen. So it makes sense to me in PCOS patients why it works.
yeah, you lost me at ovary, so yeah, it's not like eye bones,
Great diet
ovary.
for people with PCOS, okay? For everybody listening, yes.
No. I appreciate that. Yeah, look, it makes sense. It does make sense, right? When you look into it, PCOS is so like it's really terrible what we've done to PCOS and what we do to hypotestosteronism. I mean, what we do to postmenopausal women, what we do to PCOS, and what we do to men with hypotestosteronism is like a travesty. I've seen women with like masculinization from pellets that were given to them by, hormone doctors. I think they were just aggressively. I'm a big believer in postmenopausal women getting like these little microscopic doses of testosterone.
Yeah.
I do.
Doses. Yeah.
Yeah. So I do think that I'm not talking about that. There's a people who are like going overboard with this and giving women super physiologic testosterone doses, and it's just crazy. So, I think that the problem is nobody's really paid attention to these 3 subsets of people. And because they're so desperate to get something outside of the standard medicine, they're turning to anybody who'll help them and listen. And so, but it like diet, it sits the root cause at a lot of this. And if you can improve the diet, it can improve some of the hormones. And in cases that it can't, just very conservative, supplement like hormone replacement can go a long way. I mean, we've seen people like on testosterone injections, and I ask the men, like, are you feeling any better on the testosterone? They're like, no. Well, that's because nobody has addressed your sleep, your diet, your diabetes. I mean, anything else. They just saw a number and they gave you a treatment. I mean, it's, I don't know if you feel the same way, but I feel like these are really vulnerable people, postmenopausal women, PCOS, and hypotestosteronism. And, most conventional doctors won't do anything, right? Because they're like, oh, the Women's Health Initiative, oh, testosterone is going to give you a, clot, right? And they're so apprehensive to help. I mean, and I feel like these people will turn to anybody for help. So I don't know, Dr. Laura, have you seen those? Am I crazy? Am I off base here?
No, I haven't seen as many patients with, I think, what you're talking about. I have heard of it, but I think I've been lucky that I've only seen one patient who did have like super physiologic doses and significant side effects issues from getting.
Oh, you'll see it. You'll see it soon. I'm Jamie. I'm sure you've seen it, right, Jamie?
Yeah.
You know what I'm talking about, or am I off base here?
Well, I think that people feel sick and tired, and they're always looking for a quick solution. And it's like when they come in and they say, can you check my thyroid and my hormones? I think they're off. Like they think that the reason that they're like obese and tired and sluggish is because something went wrong with their hormones, and that's why they feel the way they do. So, they find these clinics, a lot of them are cash pay, and they're like, well, dude, look, you're a guy and your testosterone's 200. Like, if we just bring this back up, you're going to feel so much better. And they like that because they want that to be what fixes them. And I think that's what, Dr. Tro's talking about. Like, they're very vulnerable. Like they want, they're an easy person to sell to you because they want to feel better. And I mean, people aren't going into these places with like a normal body fat and like good metabolic health, okay.
Or getting a doctor who actually wants to fix those things. Right before they just slap on medications.
But for men listening, if you have low testosterone, restoring your metabolic health can restore normal testosterone production. For women, it's a little more complicated. For PCOS patients, it's really good at lowering testosterone and helping with some of the hirsutism type symptoms that can happen with PCOS. For menopausal women, nothing turns your ovaries back on, although I've seen women start menstruating again. And there's some interesting data coming out about stem cells and ovaries, and there could be some mechanism there with ketosis. I don't know. We'll find out. Time will tell. But okay. Let's see.
Did we get too sciencey? I was like wondering if we got way too sciencey. I don't know.
I always try to keep it really at a level where everybody can understand. Actually, my neighbor came by today and he said, I love these keto reels you're doing. Half the time I don't know what you're saying, but I know it's good information because you sound good saying it. So I end all my podcasts with something called the semen analysis. And I just pull like a recent study that I find interesting. And so I'm very interested to hear you both weigh in on this. The American Journal of Clinical Nutrition. This was just published September 30th, 2022. I just shared it recently on my social media. The title is Insulinemic Potential of Diet and the Risk of Total and Subtypes of Breast Cancer Among US Females. And this was a study, actually the Nurses Health Study. So they took data from 76,000 people in the first arm of the study, and then there was 93,000 people in phase 2 of this study. So that's a lot of people. And they basically looked at their diets and the insulinemic potential of their diets correlated with circulating C-peptide concentrations. And basically, if they had a higher score, they wanted to know if that would increase the risk of breast cancer. And they found across the board that dietary patterns that contributed to hyperinsulinemia, so high insulin from their diet, it is associated with a greater risk of breast cancer, especially estrogen receptor negative and HER2 positive, and basically suggested that dietary modifications to reduce insulin may reduce your risk of breast cancer. What do both of you think about this, the relationship between insulin and cancer?
I think there's been a lot of really good studies that are now pointing this out more and more. Obesity is associated with over 13 different types of cancers now, and is one of, saying it's the second biggest risk factor that is modifiable outside of smoking as far as a risk factor for cancer. And there's a huge correlation between insulin levels and obesity. So I think a lot of good data in this adds to it about the association between insulin, cancer, obesity.
Yeah, but you don't have to be obese to be hyperinsulinemic. And I want people to understand that as well. And hyperinsulinemia precedes hyperglycemia, prediabetes, and diabetes. I just had a young patient recently in my clinic who her doctor kept checking her A1C. She was very obese, 376 pounds, very young girl. And they kept checking her A1C. It's normal, it's normal, it's normal. I checked a fasting insulin on her. It was 71. Yep.
Wow.
Yep.
And she had severe acanthosis. I mean, just looking at her, I was like, you have diabetes. No, my doctor checked my A1C. It was normal. It was 5.4. I'm like, you have diabetes.
She's an expert storer. See, this is the thing, right? She's an expert storer. You and I know she has what comes before the disease. She's redlining, right? She's redlining. But she's like, and it's tough to understand this, and it's tough for most people to understand this. But I think in breast cancer particularly, it is so very clear that insulin and sugar are factors. If you look, the National Cancer Institute has a massive phase 3 study that comes out in the fall, the spring of next year, which is looking at metformin for breast cancer recurrence, right? Where they're literally seeing, they gave to, 100,000 women. It was some like obscene amount of women, right? They're giving, so what does metformin do? It makes you shit out glucose. Right? So what are they doing? They're literally removing glucose, right? And for breast cancer prevention, right?
It's the same with ovarian cancer and endometrial cancer. We know metformin, and there's evidence for low carb and ketogenic therapies for those cancers too.
Yeah, and there's a lot of evidence. GYN space is ripe with this stuff, and also glioblastoma and stuff like that. But for breast cancer, so the National Cancer Institute so much believes that metformin has, they're spending $3 million to do the study. So the question is, does reducing insulin and reducing blood glucose have a positive effect on breast cancer? Well, we know that the epidemiologic data lines up with that theory, right? And then we also know that we're looking into the pharmacologic, effect of that. They're literally looking at drugs to see if that's what it does. My belief is, yes, absolutely. If I had breast cancer, I would cut my carbs to zero. If I had glioblastoma, I would cut my carbs to zero, right? So that's what I would do. Is there evidence to say it'll prevent cancer? It's not clear cut. Nobody's doing that study ever. It would cost more than $10 million to do that study, and nobody's going to do it. But physiologically, it makes sense. You have the population-based data, and then you have enough interest at least to spend $10 million at the National Cancer Institute to literally see if that's the case. So I give a thumbs up to that study.
Yeah, I listened to a presentation
Yeah,
by Steve Bullock. They took a bunch of recurrent stage 4 breast cancer patients and did a pre-PET scan, put all of these patients on ketogenic diets. And if you look at their post-PET scans, I mean, they saw massive shrinkage of tumors. These were recurrent stage 4 breast cancer patients. They had already had every treatment that we know thrown at them. And I just think that it needs to start to be part of the conversation for adjuvant therapy, not necessarily as primary therapy, but it should start to be a conversation. But I think there's so many oncologists that don't understand it, like where do we find these people to help, treat these patients?
Yeah, Thomas Dayspring, and then there's a couple of others out there in the cancer space. Colin Champ, another one.
Yeah.
It's going to be a long time because that whole field is even more antiquated. I mean, look, you have a bariatric surgeon who cannot talk about a ketogenic diet. Just imagine being an oncologist talking about a ketogenic diet. It would be even that much harder.
Mm-hmm.
It's going to be a long time.
Yeah. I wanted to highlight what you're saying, Jamie, about the insulin and you're not having to be overweight, because you're so spot on. Tro and I do something called Walk with the Doc on Tuesdays, Thursdays around 9:30 on Twitter. And one of the things we discussed recently that made me think of this, 1 in 5 adolescents now almost have prediabetes. And of those 1 in 5, 16% have normal weight. Normal. And so those are in kids with normal weight even who are having prediabetes, which means their insulin levels, they're definitely already up unless they're coming back down on the other side. But those kids are never even going to get caught outside of studies because there's no guidelines to be checking for fasting insulins or A1Cs.
Yeah, no, I'm just really passionate about it because I looked pretty much like this when I had prediabetes. I mean, I was never like the obese, phenotype, and I come from a long family history of normal BMI diabetics and athletes. I mean, we had muscle too, right? That's supposed to protect you against insulin resistance. And but I was eating a highly processed diet. I went through a nutrition program where they just taught me to count calories. I talk about this in my book. Even in med school, I was counting goldfish crackers because that was the only mechanism by which I knew to get healthy. Just count your calories, keep working out, count your calories. And I ended up with prediabetes and hypothyroidism. And I felt horrible, less of a human than I should have been. So I applaud Dr. Buchanan, Dr. Tro, what you're doing. Keep doing it. Can you tell people, because you're licensed in all 50 states in the United States of America, which you guys, for those of you listening, because I get asked this all the time, I have patients who fly to Nebraska to see me. Because I only see patients in Nebraska because that is the only state in the United States in which I'm licensed. And as a provider, we have to be licensed in the state that the patient lives. Now you're like, okay, well, how do they fly? Well, if they fly to see me, now they're physically in Nebraska, so I can see them here. So, but I don't do telemedicine. You guys treat people in all 50 states. So tell people how to find you, how to work with you, how to hear your podcast, all that.
Yeah, so I'll take a stab at that. So, the vision of the practice is basically a nationwide practice. Dr. Laura Buchanan is coming on board, and hopefully we'll be adding some more doctors actually to that lineup. Why 50 states? Because everybody deserves metabolic health. And literally, I was scrambling to find people calling me to find who can see them so they don't have to come fly and see me. I had somebody who literally had their husband donate blood and sperm so that they can pay to come see me. And the minute that happened, I was like, this can't happen anymore. So we are a nationwide telemedicine practice. We do weight loss, metabolic health, and primary care, virtual primary care, which means we're kind of like a metabolic health adjunct to your current team. You can find us at drtro.com, spelled out DOCTORTRO.com. All social media, Dr. Tro, spelled out. We got the Low Carb MD podcast. If you're on Twitter, Dr. Laura Buchanan, MD is her Twitter handle, and we do Walk with the Docs where you can just join us, ask any questions, we chit chat, and it's kind of like a cool thing. Tuesdays and Thursday mornings around 9:30 Eastern. Dr. Laura, where else can people find you?
Yeah, I've got agingsuccessfully.substack.com. So that's, part of along my passion with joining Tro's practice. I've said kind of one of my big life goals is I want to help as many people as possible age successfully. And so this talks about all different topics on hopefully how we can help people along that journey.
I love it. I love it. Thank you guys. Thanks everybody that is listening. If you guys wouldn't mind forwarding this podcast to somebody that needs it, that needs help, that would find it interesting, send it to your healthcare providers. Maybe they want to listen to it. But leave us your comments and your questions and your reviews too. We seriously appreciate all of that. So Dr. Tro, Dr. Buchanan, thank you guys.
Thank you. It's been a pleasure.
Thanks.